To moderate the discussion, we have Dr. Sarah Viebeck. She's the Chief Scientific Officer, or Science Officer of the Public Health Agency of Canada, which she's a role she's held since 2022. And she's responsible for providing strategic leadership to oversee and support science excellence, science policy integration, and science promotion, as well as re-energizing the scientific vision and capacity towards strengthening the voice of science across the agency. Prior to taking on this role, Dr. Viebeck served in a number of roles in the Canadian Institutes of Health Research over 12 years, including as the former Assistant Director at the CIHR Population and Public Health, and most recently as CIHR's Associate Vice President of Research and Strategy. So welcome, Sarah. Thank you.
Thanks very much, Tim, and thank you, Dr. Von Kerkhove. This week, we celebrated the International Day of Women and Girls in Science. You have been exemplary at illustrating on a global stage, day in and day out, what excellence in women and girls in science means, and demonstrating a career path for women and girls in science. And I thank you for that, alongside your many other contributions. I think we heard from Dr. Von Kerkhove that there are a number of opportunities to knit together the local and the global, from protocol development to sharing data, to dashboarding and communications about the reach and potential of results, around collaboration and both the scientific and applied contributions for action and response, and around the importance of strengthening capacity and community engagement. And we are going to get a couple of great respondents. I'm going to ask Drs. David Buckridge and Alison Spalding to come to the podium as I introduce you. David Buckridge, you met yesterday, so I'm not going to repeat his full bio. I'll simply say he's not a stranger to those of you engaged in this effort. He's a professor in the School of Population and Global Health at McGill University. He directs the Surveillance Lab and is an advisor to many around public health surveillance capacity and digital health transformation in Canada and globally. He's also a Canada Research Chair in Health Informatics and Data Science. And Dr. Alison Spalding is an epidemiologist with expertise in infectious diseases, pandemic preparedness, and antimicrobial resistance. She's a senior advisor and team lead within the National Institute of Allergy and Infectious Diseases Vaccine Research Center, and she leads the PREMIS program, which aims to serve as a translational vehicle to integrate serologic and cellular immune discovery into medical countermeasure development for pathogens of pandemic potential. We're very fortunate to have both a Canadian and two international experts to guide us through the discussion. I'll invite each of you to offer sort of 5 minutes of reflection and opening remarks before I follow up with a few questions. Thanks very much. Why don't you go ahead? David.
Oh, sure. Thank you. Thank you very much for the introduction, and really a wonderful presentation, and so much was done in this space during the pandemic, and I think it was a pleasure to be involved in this, both in terms of working with the SeroTracker team to help with some of that data preparation, but also with trying to draw some insights from the data. And so I'd like to sort of focus on a bit of that perspective. What was a bit of the challenge and I think the opportunity going forward in that space. So, I think one of the challenges we found, not dissimilar to the challenge in Canada, though I think in Canada we were very lucky to have a rich volume of data, much of which we heard about yesterday coming from blood operators and other sources. The situation on a global scale was a little more scattered. There were certainly the structured studies designed by the World Health Organization and supported in that way. But even the sort of administration and the timeliness of those were somewhat variable. So I think there's a real kind of operational challenge in terms of how those data are brought together in real time or as close to real time as possible, but also a question about how you fill out those gaps in the data and even in fact, more importantly, understand the variation in quality in a way that can be actually worked into an analytic process. So, and this goes to not just the direct data on serosurveillance, but also other data that you would need to really interpret those data. Because ultimately with the serosurveillance data, you're trying to, get at many points of inference, but one really is what's going on in terms of infection. And in many countries where there may have been surveys going on, or serosurveys, there was differential capacity to do case reporting, differential quality in hospital and in mortality data. And so it very hard to triangulate in that kind of a setting. And I think, the work that was done over the course of this pandemic in trying to put together different data assets and align them was really remarkable. But a lot of it happened kind of on the fly. And so, I'm delighted to see a little more of this, the fact that SeroTracker and the World Health Organization have bridged a closer collaboration, or a stronger perhaps going forward, because it's those kinds of partnerships that are going to be really critical for not only, capturing the data, but also pulling it together and making it accessible and documented in a way that can really support drawing the insights that we need to draw. So maybe I'll just leave it there in terms of my opening remarks, but again, I think it was amazing work and great to see it moving forward. And I think, a lot was done in this space of analysis, but still I think there's a lot of thinking that has to be done in terms of how we better document the variation of the data and think about how to move that into an analytic process or pipeline that generates the timely insights we need on a global scale, where we have some more uniformity perhaps in the certainty of our inference and assessments that we're making.
Thanks, David. Allison.
Yes. Good morning, everyone. It was an excellent presentation, and it's very exciting to be here. Yesterday was a wonderful day, and I got a chance to hear a lot about all the activities that are ongoing. So I'm going to speak later today about the PREMISE program, but in brief, we are a pathogen-agnostic, immunologically focused pandemic preparedness program. So this actually connects very well to what we're discussing here today, because we're really in the translational side. And so we are using that Sero-Epi and the surveillance data to really understand how to strategize our work. Given that we are pathogen agnostic, we have a long list of viruses that we target, but we strategize within that list of viruses based on what our partners internationally are focused on. And then, of course, we're looking to implement our countermeasures, so monoclonal antibody vaccines, with partners in areas where they would be most impacted by those different diseases. And so we're really using information in real time to figure out which viruses to prioritize for our program, and then once we have countermeasures available, how to get those to partner sites to see if we can get them involved in early human clinical trials, and then of course once products are available to get those to those locations where they'd most be needed. So looking forward to the discussion. Thank you.
Great. Thanks very much, both of you. So I think we heard from Dr. von Kerkhove about a number of actions that are required to knit together a system for serosurveillance capacity. I'm wondering if you could both reflect on what actions you think are needed to strengthen the science of serosurveillance as an element of the core surveillance functions within public health.
Sure.
You can take these in whatever order you'd like, and then we'll come to you on screen, Dr. von Kerkhove.
Okay. Sure. So a few areas there. One, I think, is just sort of a fundamental understanding of variants and assays in terms of what they're measuring and how to interpret them. Even we've noticed some distinctions between dry blood spots and venous sampling, and sometimes we don't always have those different approaches to sampling on the same assay. So it gets quite complex, and you're often trying at the same time correct for differences, different assay differences in sampling, which is also not well defined. And so I think there's really room for fundamental research there. I say fundamental, it's really more applied research, I should say, where you're trying to really discern the differences between those assays. And I think there needs to be some kind of loop probably back to the assay development process to ensure that, when you try and pull this together at a population scale, you can make sense of what you're seeing. So that's one important area. The other area is what I was alluding to before, which is how do you put all this together and what are you really trying to get out of it? So I think, we did a fairly good job in CITF and in some work with WHO of taking many different serosurveillance estimates, point estimates from different sources, and essentially doing time series modeling of those estimates, which was somewhat useful to see what seroprevalence was doing over time, but we often are really trying to think about what's happening with infection, not seroprevalence. And so once you bring in waning, changing in different variants over time, it becomes very difficult to back out of that seroprevalence time series a meaningful interpretation of underlying infection. The modeling can get quite complex, but a lot of that work we were trying to do on the fly during the pandemic. and I've yet to see a really well-done approach to that. So I think there's still room for, basic statistical or applied / basic statistical, biostatistical machine learning research in that space. How do we really bring together these different sources, understanding all those issues I mentioned, even with sampling, different assay platforms, to try to get the inference we need? I think there's a lot of opportunity for research there as well.
Great, thanks. Allison?
So I think, definitely agree with all those comments. And then the standardization is so key to what we are trying to do. So understanding how samples were collected, which populations they came from, and then really, because it's so vital to our work to have PBMC access, understanding, who has samples already stored, do they have leftover samples that we can use, how were they processed, understanding those protocols. So to make sure that it would have cell viability. And then, with premise, we may end up carrying forward some of our countermeasure development into early phase 1 trials, but really we're looking for our international partners to do that, as I was mentioning. So the availability for doing clinical trials in various settings is also information that's very vital for us to know as we move forward in our program.
Thanks. Dr. von Kerkhove.
Thanks. You could definitely call me Maria, and thank you very much for your kind words. But no, I'm agreeing with all of the comments that have been made. I think making sure that we are able to advance the work on a number of aspects. The research, I hardly agree. I think there are some very fundamental unknowns that we don't have great seroassays. It depends on the pathogen that we're talking about, but there's a lot more work that could be done there and the standardization of that. For us, it's about identifying what those priorities are and then working on the global stage of who can do what. What we try to do is we try to coordinate some of these activities so that there are multiple avenues of research that are being undertaken at the same time, that we're not duplicating, that the research is complementing each other and building on each other. And we do that through partnerships. So we at WHO, we don't have labs here, though people thought we had labs here during the pandemic. We don't have any labs here. We work with labs around the world. We work with researchers around the world. And that partnership is based on trust. It's based on long-standing history, and that advances everything. So David, I just wanted to mention on the Sero Tracker, it's been such a fantastic collaboration that we've had. And it is about the visibility of these results and the accessibility. We've demonstrated with the Unity protocols that we've democratized this in many ways, because it's not just the high income countries that could do the work, it's around the world. And we're discussing with Sero Tracker how we can visualize the arbovirus serology and even beyond. So there's just, all I see are opportunities, but just agree with the comments that have been stated so far.
Thanks very much. I'll ask one more question, but I'll also invite folks in the room to come to there is one mic, right, Carolyn? Yes, at the back of the room there, if you'd like to ask a question of our panelists. Thanks very much for those reflections. I would welcome your reflection on how enhanced surveillance through seroepidemiology can be used more effectively to inform public health responses and policy decisions in real time. You've spoken a bit about the challenges and the areas for research and scientific growth, but what do you think the greatest potential uses are?
Guess I'll start again. So I think about this a bit more in terms of obviously it's going to differ in terms of the pathogen that you're thinking about specifically, but I think serosurveillance is a piece of the puzzle, as it were, when we come to any kind of surveillance activity from a public health perspective. It has many great assets in terms of I think for the most part, its sensitivity in the population. And depending on the sampling strategy, it can give you a fairly unbiased sense of who's been recently infected or even vaccinated, depending on, again, the assay and the organism you're looking at. But it lags. It lags by, in terms of the antibody response and in terms of just the logistics of getting those data out and available. And that lag can be quite pronounced, as has been shown, both in terms of publication sort of delay, if that's the mechanism of reporting, but also just in the challenges of getting those data to a centralized location or available. So I think what's interesting to think about then is how do you use that data in a surveillance context to maximum effect? And I think it really is by combining it in a And I mean that in a sort of structural way, either through statistical modeling or machine learning or some kind of an expression of how we expect the serosurveillance data to vary in relation to other indicators we have that may be easier and more timely to access. Wastewater was a great example, genomics in terms of variants. How do you put these things together in a way that you can really get that inference you're trying to get on the time scale that you're trying to get? There has been some work in this space, and I think there's a lot more that could be done. But in my mind, that's kind of part of the puzzle, because once we have a sense, almost in a laboratory or offline sense, how that can be done, it starts to inform our thinking about surveillance platforms and investments and integration. Because ultimately, at the end of the day, I don't think we're going to get a lot farther if we run a number of independent parallel systems where we get information out of it and it all just kind of comes into a bucket and it's left to humans to try and make sense of it. I think that's kind of what we're doing. It kind of works. I think if we think a bit more about how to exploit our understanding of how these things relate more explicitly, I think it'll be very helpful then to build out from that kind of a perspective what sort of platforms make sense and what can be done in terms of driving towards much more timely and comprehensive decision making. I'll just say one big challenge in that space before I pass on to my colleague here is, of course, that things change. And so, we have been working to try and do joint modeling in collaboration with the Public Health Agency of Canada, actually, around wastewater surveillance and serosurveillance. And we can show very nice relationships over time where we can actually do good forecasting in the kind of way I was describing. And then the variants of Omicron arrive, and that relationship changes, particularly in wastewater, quite rapidly, in ways that we couldn't have probably anticipated. So these models that I'm talking about, this approach I'm talking about, there are challenges, but I think that can be overcome with further research and further experience.
Thanks, David.
Yeah,
Alison.
so I think, as I was mentioning, I mean, the real-time necessity for us is very prevalent to the work that we're doing. And so, based on what serosurveillance and seroepi is finding, we're able to adjust the strategy for our program directly. So, as I mentioned, we have, being pathogen agnostic, we have 88 viruses on our list. We have 6 in the top, but we're able to change those priorities as things emerge, as trends emerge. So for example, Lassa virus was probably like number 7 for us until recently, and now with the latest outbreak of cases, we've moved that up in our priority list and have decided to focus a lot more of our work in that area. And so we're able to real-time use that information to decide how to prioritize our team's efforts and our work moving forward.
Maria.
Yeah, I mean, I see so many practical applications for seroprevalence and serosurveys. I do agree that it's a piece of the puzzle. It's an important one. My background is in H5N1 and field studies, and we use serology to really understand transmission patterns, to understand the extent of infection, to estimate some key epiparameters. Those are absolutely critical in the beginning of anything. Whether it's a known pathogen or an unknown or a new variant of one, we always ask the questions of like, what is it? How is it spreading? Who is it affecting? What can we do? How far is it spread already? But in my entire career, we've used seroprevalence studies with molecular testing and now sequencing to understand transmission between humans, zoonotic transmission, depending on the setting, looking at, what's the R naught? If you remember in the beginning of this pandemic, one of the key parameters we needed to understand was household secondary attack rates. We were obsessed with this in the beginning days because we didn't understand how much this virus had actually spread. It wasn't even really identified yet, and people were being put in their homes, and we had no idea of the extent. We didn't understand symptomatology, we didn't understand the infectious period, but understanding secondary attack rates was one of those key parameters. These studies helped us do that really quickly. And I think what we're trying to do with the protocol and the standardization of them is to make this much more routine so that it's not a standalone, that it's a new thing that has to be done each time. And I think during COVID, we crossed that barrier. We crossed that hurdle because there are so many other countries now that can do this. And it's a relatively small investment compared to some of these huge population-based studies that are out there. So, and of course, the localization of the work, the use of the results to actually inform what happens next, that's our goal. yes, it's great to be able to combine and do regional meta-analyses, global meta-analyses, and that's wonderful. But really what we want to see is sort of local use, local action, immediate. So lots of different utilities. I mean, I covered some of it in my presentation, but we've always felt very strongly that this is a really important consideration, and it's part of the fundamental suite of surveillance activities that need to go forward. And I think that's catching on. It's expensive, but it's catching on.
I'm going to follow on there and just ask what you believe are the essential capacities at the country level to invest in for rapid seroapi as part of an enhanced surveillance approach and that overall suite of surveillance. Yeah, we'll come to
That
you.
for me?
We'll change it up. We'll come right to you because I think it follows on from what you just said, and then we'll go to our panelists. So, what are those essential capacities at the country level that are required?
Well, what we're trying to do in terms of capacities is to think more broadly of what capacities are necessary. It's not to evade the question, but we don't want to have capacities just for seroprevalence. We want capacities for surveillance. You know, we need to have good laboratory systems that are in place that have the ability to do molecular testing, to do serologic testing. Serology is not as straightforward as molecular testing, of course. It depends on the assay. Some of the assays that are out there are really poor. There's a lot of, we were calling it snake oil at the beginning of the pandemic. Very easy to purchase, very cheap to purchase, but they didn't do anything. They didn't tell you anything. And a lot of governments initially purchased a lot of the rapid serologic tests because they didn't have access to PCR, and it was something, but it wasn't actually used for its, to actually detect cases and get patients into a clinical care pathway. So major capacities around a workforce, to be able to carry out different types of studies or to carry out, community-based workers are absolutely critical. Good laboratory systems that are well-resourced, well-financed, to be sustainable. There's a lot of equipment that exists in countries. We don't want equipment to sit on a bench and not be used. And what we're trying to do is the capacities that we have for surveillance, and I include serosurveillance in this, a lot of them started with a disease-specific lens because that's where the money came from. There's COVID money that did this or flu money that did this. And when that money runs out, those capacities stop or that activity stops. And what we're trying to shift to is capacities need to exist for the pathogens that are in circulation that you know about and the ones that may be circulating that you haven't yet detected. And so, for example, while SARS-CoV-2 demand goes down for PCR-based testing, for example, or serology, the demand for other pathogens that are in circulation should fill that void. And that's how we can keep that up. It's hard to sell right now. There's the pandemic fund that's out there that's focusing on surveillance and laboratory systems, and seroprevalence studies needs to be part of those applications, as well as the PCR-based systems, the wastewater systems, et cetera. So it's more broad from our point of view, as opposed to just specific capacities for the serosurveillance.
I think that fits well with the reflections from Allison around pathogen agnostic approaches and David's reflection on platforms for surveillance. Any comments from you around, David, you were very involved domestically. Maria, I think, nicely reflected on the importance of capacity retention. What would you be prioritizing in that regard? And then we'll come to you, Allison.
Well, just to say, I think Maria's answer was spot on in terms of, you have to start where people are at and make sure that you're trying to, bring things up in terms of overall surveillance capacity. One area I think that perhaps I could add there is around the data infrastructure, the digital infrastructure to support that, which I think has to be part of any thinking about how you build up your surveillance capacity. And the model, even in Canada, we see inequities in that area where there's a lot of differences in different, for example, provinces and territories and their ability to do serosurveillance, data management, analysis, and reporting, and so on. So I think, thinking about how you build capacity on the ground, enhance those skill sets, it really is a lot about the people. Infrastructure, is important in this space, but a lot of this infrastructure can be accessed in an open source way, or if you have the right people with some resources, you can get it done. But there needs to be a network, and there need to be standards that are understood amongst the people working in that network. And it needs to be this sense of not just data flowing up into a black hole, whether that be at the province public health or country public health or WHO, but more of a kind of a flattening of that relationship where you really are, I think, as Maria said quite well, using the data for maximum effect locally, and also making that data available for others so it can be pooled and analyzed, but then pulling from others too, so you can better interpret your local data. So I think we need to think about, what is the infrastructure that can support that kind of a work process, and of course, the competencies that are needed to enable that in practice.
Allison.
Yeah, I'll just echo that sentiment. I mean, for our needs, again, linking the data that's available at the patient level with the samples is key. We need to know if samples were collected during a symptomatic phase, or, what was the situation with the patient when it was collected, so we can strategize our analyses. And then just, we work with a lot of our partners in regards to sample storage, sample acquisition. Are they able to store PBMCs on site? And then also, and as I mentioned before, how was the protocol? Was the protocol used for the processing? And then, if PBMCs aren't available, do they have the ability to bring people back? So are they able to track in their system, these are the samples collected? Is there information available to reach out to those people again to get access to additional samples if needed?
Are we accepting questions from online?
We are. So Varun is at the back.
Okay.
Signal to you if we have online questions.
Okay, good. And then I'm going to go to our colleague at the microphone. Hello.
Hello, I'm Ligia Pinto from the Frederick National Lab here in the US. Maria, excellent talk, and also congratulations on Concise. We are doing a very similar work since 2016 on HPV, human papillomavirus serology standardization. And it's so important because it actually resulted in a public health change. Data from that, work and results from standardized testing have contributed for recommendations by WHO for 1 dose of HPV vaccine. So for that, of course, the quality at the low end and low levels of the assays is very important. So standardization of the technologies was extremely important. I would like to ask you one question and then maybe a comment, but so within Concise and talking about that lab capacity, do you have a repository of standardized reagents, not just the international standard, which is extremely helpful, but also potentially national standards, critical reagents that can enable, and training too, that can enable then the laboratories to increase capacity, but at a standardized testing level?
I'm going to actually ask, we have a few people at the mic now, so I'm going to get a few questions through, if that's okay. And then I'll turn it back to the panelists to reflect on the questions as a set. Kate, please.
Yeah, hi Maria. I feel like I know you. I've been watching you in the WHO Q&A and the press conferences and everything. I'm the former co-chair of the task force, and I just want to really appreciate your science communication. You've been incredible. My question is, how do you get decision makers, funders, to value the contribution of seroepidemiology in this panoply of case reporting, mortality, hospitalization rates, the wastewater? I mean, how do you communicate how important it is that you started to do that. We have this capacity. How do we continue the capacity? How do you sell it? That's my question.
Thanks, Kate. And then the final question in queue, and we'll turn it back, and I'll just get people ready. Allison, we're going to come to you first, and then David, and then Maria, so people can prepare.
Thank you very much for all of the insights. It's wonderful to hear. And I was wondering, with respect to standardization and collaboration, we talk a lot about collaborating and standardizing across academic institutions, public health institutions. But are there any efforts, and what efforts might there be to maybe engage more with biotechnology companies and industry to be able to standardize the assays at the source, the reagents, the approaches, the sample types that are amenable to be tested on them?
And Varun, I don't see you, but I don't have my glasses on, so that's a bit hopeless. No, that's a head shake. Okay, we're going to come to Allison, David, and Maria. So the questions related to repositories for standardized reagents and also training, how you get funders to value and communicate the importance to funders of serosurveillance as part of a surveillance suite. And the last question was really around cross-sectoral collaboration, including industry engagement.
So I definitely don't have a clear answer to any of those questions because they're all things that we deal with in our program, and yet we're doing our work, producing our medical countermeasures and just trying to move things forward. And we do have industry partners, but it's a huge challenge for us because the vast majority of the viruses we target have limited to no real commercial market, let's say. And yet we just keep moving forward with the work, and I'll really cede my time to the other two collaborators here because I think they're going to have a lot more to say on these topics.
Sure, I'll take one of these anyway. I'll go with the sales pitch one. Kate, I'm sure Maria has things to say on this one too, but.
It's a good reframe, Kate, of your question.
It's not exactly what you said, Kate, but that's the way I'm going to frame it. So, I think it really is, I would pitch it as an anchor. I think all the other metrics or indicators you mentioned are biased in ways we don't really know, more so than serosurveillance. I'm not saying serosurveillance doesn't have many unknowns, but I point to the example of when Omicron variants arrived. The really only source of anything close to truth was serosurveillance at that time. Now, that was a bit of a combination of circumstances, I think. It could have arrived differently, and certainly as more variants arrived, the picture became or murkier, you might say, in terms of what was going on. I talk about trying to infer infection now, is really what I'm focusing on. But I go back to my anchor point, I think, and the comment I made before about trying to actually put these in a joint model, a statistical model, a machine learning model. It really is the serology, and you can show this analytically, that is anchoring everything else and providing that sort of stability to interpret the other indicators that are also changing over time. So I think there's that element, and then I think it's also clarifying the use case. It's not a panacea, it's not for everything, but there are very strong use cases, both in infectious diseases and other areas. And I think I think also, as Maria's mentioned before, thinking about these as kind of platforms. And that's where I think you can start to bring in the value proposition, because you're not doing it for a single disease. This is something that could work for endemic surveillance, conditions that are endemic, as well as emerging and new organisms that might appear. So to me, it's about the anchor, and it's about clarifying that use case or set of use cases.
Maria.
Yeah, thanks. So on the first question, Concise isn't really operational right now. I mean, we went a little defunct for a little while, and everybody kind of went back into their worlds, but what we're trying to do is bring it back. Having said that, we didn't have repositories for standards or reagents. We did work with NIBSC, for example, to do some work and looking at this. Doesn't mean we can't, but WHO wouldn't host this. Like, we don't have labs that could do something like this. We work in partnership. And I think it's a good question of what could be done and how we can share these materials when and where needed. On the training side of things, Concise hasn't developed any trainings, but could. And work with us. We have something called Open WHO, where all of our trainings are. They're translated into dozens of languages. We have a lot of lab training that are on there. I don't know if we have any serology training. We might, but we could look into that. And especially if something needs to be done rapidly, it's a great way to disseminate certain types of information. The question on how to sell it, I think it's a great one. I find myself in a really strange position globally. Like, we've all gone through this massive pandemic. We're still in it, but the crisis part is we're not at that same level of crisis. And yet no one wants to talk I can't even mention COVID, half of the places where I'm in. There's no political interest in this. Everyone's now moved from pandemic preparedness to climate change, which is a massively important topic and deserves attention, but it's all interlinked. So it's really interesting. And I think part of this is the trauma that we've been through, and we don't want to deal with it, and we just want to move on. But our responsibility here at WHO is to make sure that what has been done is not lost, what has been done is not stopped, and that we utilize, responding to COVID is pandemic preparedness for the future, and that includes seroepi. But I think the way we've sold it is one study at a time. In every country where we have utilized these types of studies, my training was in Cambodia, and we did these serosurveys. They weren't called Unity studies or anything like that. We did it every time there was a human H5 case. And we demonstrated within that village the extent of infection, what was actually happening to inform control efforts. And that was done at local levels. It informed the ministry. It informed utilization of very scarce human resources, on the human health side, but also human resources on the vet side, you know, reagents or whatever we had, materials, time, money. We did this in Qatar and in Saudi with MERS and identifying dromedary camels as the intermediate host. I mean, we sold it one thing at a time, but I think in the pandemic, it really, really took off. And countries saw, particularly those first few hundred, that protocol, the household transmission, really showed how countries could use that information. And in engaging with industry, so we, as WHO, we have public-private partnerships, we engage with industry, we check everybody's conflicts of interests as well. So of course, we have to make sure that what we advise to all of our member states, helping everyone everywhere, takes those interests into account. But I did want to comment on something Allison said around the commercial market. I hear this all the time. People say to me all the time, there's no market for any of this. Yet, we just went through 4 years, now in the 5th year of a pandemic, of a virus that is novel, that affected every single person on the planet. Manufacturers, industry made billions of dollars off of this. And then to come back and say, there's no market to invest in this, I think is absolute rubbish. I get it that there's like there's this once in a lifetime kind of events, which unfortunately I don't think will be once in a lifetime, but we have to change this narrative that there's value in assessing all of these pathogens, whether it's through risk assessment, whether it's the development of diagnostics, the seasonal patterns of what we may see, as well as the outbreak, epidemic, pandemic cycle. But I think we really have to shift that narrative of what is the value of doing all of this type of work on a day-to-day basis.
Thanks, Maria. Lots of appreciation. It's always hard when you're joining remotely, but I'll just reflect that there's lots of appreciation in the room for your most recent set of comments. My thanks to Allison, David, and Maria for your really thoughtful set of reflections. I think you spoke about the importance of having networked and collaborative capacity in a continuous way, the power of serosurveillance as a platform that needs to be situated among other platforms, whether that's wastewater, genomics, other forms of surveillance, and the really critical importance of standardization of methods and of measurement tools. So I did also hear a number of comments around some research. Maybe it's fundamental applied research. That's not a thing, but I think, David, you were really reflecting importantly on the importance of getting at some of those upstream questions around how we measure, how we standardize, how we pool data, et cetera, that are also fodder for subsequent research. So thanks very much to the panel. Please join me in thanking them, and thanks to folks for questions.